a session. It's the third time that we do that. We like it very much, and we would like to keep doing it anyway, in collaboration with ESGE, Hellenic Society of Gastroenterology, has this traveling endoscopy program in the session in the Congress, and I have the honor to have as my co-president Professor Hassan, who is Italian, from Milan,
Ciao.
and the current president of ESGE. So we choose some things, some common issues that are of interest both for our Hellenic Society and ESGE. And would you like to say something, or just start?
So I thank Constantina for this session. Of course, the Greek Society is one of the most enthusiastic society in ESGE, also for the excellent quality of your scientific output. We have Kostas, we have Ioannis, we have Paris, we have a lot of Greek energy in our board, and probably you are one of the most influential society in ESGE. And having said that, I feel that we can start.
We can start then with your lecture that we're looking forward with the title Tips and Tricks to Improve My ADR. As you know, in Greece we have recently launched a screening program for colorectal bowel cancer with FIT, not with colonoscopy, but nevertheless we would like to increase our ADR. So please, give us some tricks.
So the first trick that is very important is that whatever it takes, you need to come to Milano in May. It will be very nice weather, like here. And in order to do this, you need to submit an abstract. You have two choices. Either you submit an abstract, or I cut your throat. And honestly, you know, Italian mafia is very capillary in this. Okay, let's talk about adenoma detection rate. This is the 10-year program in Germany that show that the adenoma detection rate is increasing, and probably also here in Greece and in Italy is increasing. This is even more somewhat inspiring, because 10 years ago, at the beginning of 2000, 60% of German endoscopists had an adenoma detection rate less than 17%. Today, more than 60% of German endoscopists have an adenoma detection rate that is more than 35%. So the situation radically changed in good. So how did we get there? So everything started in 1997. There was a very young guy in Indiana who was named Doug Rex. Indiana University was very famous for biliopancreatic endoscopy, but this big young guy didn't like to do ERCP, he wanted to do colonoscopy. And at the beginning, the enemy of colonoscopy was barium enema. Barium enema was the most widespread technique for colon cancer, and radiologists were laughing at us. So the idea by Doug was to say, look, radiology means cancer. And he started to measure the miss rate of barium enema. But while doing this, Doug Rex also realized that at colonoscopy, you can miss cancer. And in particular, non-gastroenterology, like primary care physician, miss more cancer than gastroenterology. So this is how everything started, from cancer, not from polyp. 2 years later, Doug Rex went in his room, in his department, and he realized that not only we miss cancer, but we also miss polyps. And we miss 1 every 3 polyp. And then he did this paper on quality, where he admitted the colonoscope is an imperfect scope, and it is very difficult to look at all the endoscopy surface, and this is why we are missing polyp. So how to solve this situation? At that time in the United States, there was some rumor that the withdrawal technique could be associated with the miss rate. This again by Rex showed that the miss rate was associated with the lack of the exposure of the proximal fold with the cleaning. There was no split preparation at that time, and with the distension. And he put this in his first paper on quality. And this started the quality era. But this is the paper that changed everything. This Robert Barclay is a very strange person, because he did only 1 article. He put it on a New England Journal of Medicine, and then he didn't publish anything more. But his New England really changed colonoscopy, because he said that the withdrawal time is strictly associated not only with adenoma detection rate. You may see 11% versus 30%, 3-time difference, but also with advanced adenoma. There is a 7-time increase in advanced adenoma when the withdrawal time is more than 6 minutes. And this is why we need to be extremely meticulous in our withdrawal technique. This is an example that comes from Doug, where you may see that you need to exploit all your movement that you can do in colonoscopy. You need to rotate, you need to insufflate, you need to clean, and you need to use advanced imaging. So to detect this very subtle serrated lesion, you really need to be very meticulous in your exposure. And this is why withdrawal time is recommended key quality indicators by our society. Then in 2010, a lot of technology innovation came, and the first was advanced imaging. The first advanced imaging was high-definition endoscope. Today, all of you probably have a high-definition scope in your institution, but 10 years ago it was not like that. It was Doug Rex again to show that with the high definition, everyone has a polyp. He could find an adenoma in 67% of the screened people. Before it was about 20, 30%. So suddenly, high definition increased the adenoma detection rate to 70%, something that was even not imaginable before. And this is the meta-analysis by Costas that show that overall the high definition increased the ADR by 13%. And this applies to the Fujifilm advanced imaging and to the Olympus advanced imaging that is named the TXI. And this is a video with TXI, where you can see here in white light, it's quite difficult to see this serrated lesion. But then if you, or maybe, yeah, then if you switch to TXI, this become easier. Or anyway, TXI improve, yeah, this is, no, this is NBI. Anyway, TXI improve the contrast between the lesion and the surrounding mucosa, and it allows you to detect all of these very subtle serrated lesions. What did ESGE recommend? ESGE recommend the use of high definition endoscopy, and if you have a chrome endoscopy, at least in the screening procedure, you can use them. But probably the most important advance in adenoma detection rate has been split bowel prep, and ESGE was the first society to recommend it. This is the meta-analysis of 4 trials. One trial was done in Italy, and all the trials show that with split bowel prep, you increase the adenoma detection rate by 30%. This is without any changes in your endoscopy. This is why there is a strong recommendation by our society for split bowel prep, whatever laxative you use. Then there was the idea that you should expand the field of view. And when I was young, it was fuse the colonoscope with 3 cameras to be somewhat the protagonist, but then it didn't work very well. So you need to expose, you need to flatten. Today, you cannot use fuse because at the end it didn't work. Because the fuse scope was a very bad quality scope, and you couldn't get very easy to the cecum, you couldn't the loop, etc. So the fuse was replaced by endocuff. Endocuff is very easy to use. It works both in the proximal and in the distal colon. Maybe it works better in the distal colon, and you may use all of these frontlets to flatten the mucosa that is in front of you. You see that immediately after there is the fold, so it means that before the endocuff was effective in flattening the fold. You see how you need to go in, out, change rotation, use the cuff. So colonoscopy is very dynamic exam. It's not passive. You never go in and out with the same angle. So this is the tip and trick of a colonoscopy. Always need to rotate. And endocuff is a great tool because it increases the adenoma detection rate by 18%. Sometimes it may create some pain in the insertion, but having said it, it is a great tool. Then it was now 7 years ago that the first artificial intelligence came in. This is the artificial intelligence by Medtronic that detect any polyp in a FAP patient. ESGE did a guideline that was based on the benefit and harm of artificial intelligence. The benefit is clear because it reduced by 50% the miss rate. So you miss only 1 every 6 polyp rather than 1 every 3. And there is a substantial increase in the adenoma detection rate. And if you compare artificial intelligence with chrome endoscopy and with endocuff, artificial intelligence is the most effective tool in increasing ADR. So is this the end? Yeah, probably yes. At the end, we are improving. This applies to Germany, but this also applies to Greece, and this applies to every country. But we are also making a lot of overdiagnosis, because by increasing the adenoma detection rate, we are also increasing the number of of hyperplastic polyp that we remove, and you know that a lot of patients come for surveillance only for a hyperplastic polyp in the rectum. And because of more patients with multiple adenoma, we are doubling the post-polypectomy surveillance, and at least in Italy, the waiting list for colonoscopy is already 1 year, so how far can we go? And this is why in ESGE we are trying to be very, very, very reluctant to recommend surveillance for polyp, for Barrett, for gastric metaplasia, etc. So this is it. So the withdrawal technique and the split bowel prep really make a difference in colonoscopy. Probably artificial intelligence is already in a lot of endoscopy will make a difference. The problem is that artificial intelligence creates much more false positive than any of the previous technique, and it costs much more. So probably the winner are withdrawal technique and split bowel prep, with endocuff and AI that are in between, and the same with TXI. So this is the last slide, but this is the most important, so please come to Milano and especially submit your abstract in the next months. Okay, Costantina, maybe
Excellent.
we do after the discussion.
A short question, maybe. Can I ask you something?
Yeah.
I was wondering, in everyday clinical practice, right? We need to do a lot of things, and we, in order to have a high adenoma detection rate, and the time slot for colonoscopy might be something to do all these things, retros, etc., 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 something like an hour. While everyday practice, there is a need for many colonoscopies, so it's really struggling situation. Do you think that artificial intelligence could reduce the time slot for colonoscopies while in less than 8 minutes withdrawal time, you may maintain your adenoma detection rate?
Yeah, so this is a very good point. So first, artificial intelligence, especially large language model, will reduce all of the administrative part of colonoscopy, because in 1 hour you need to do the report, you need to do the photo documentation, there is all the part related with the device that you use, etc. So artificial intelligence will cover all the administrative part. And probably artificial intelligence will allow to do a withdrawal time less than 10 minutes. And this would be a very good trial, because we did a similar trial with endocuff, where we reduced the withdrawal time and that there was no difference, but we didn't do with artificial intelligence. So this is a good idea by your president. Do a randomized trial in using a 10-minute withdrawal time plus AI, and AI without a fixed limit in withdrawal time. So probably this will answer your question.
Could be cost effective, yes.
Yeah,
it could be most effective.
Okay, I come there, so we move on.
Thank you. Thank you very much.